down to. But talking about need and talking about weather, it kind of puts us right into what we're going to be talking about today, right? I don't know how we do that.
Oh,
It's like we plan it and we never plan this.
preemptive
Yeah.
though. Yeah. So, appreciate everybody joining in today. For those that missed last week's webinar, I'm going to post a link to it in chat, the full video. Do recommend watching that one. We've done a couple sessions on this, but we talked about the our breach incident naughty list. And for those that don't know, um, once your practice or business undergoes a breach, may end up on this list. It's on the HHS.gov OCR breach report portal.
If it's
And
north of 500, it's on that list.
yes,
On
there's
straight on the website.
more than 500 patients affected. You will end up on this list. And
Yeah.
yeah, we just had a good episode, sort of talked about a couple examples on here. And yeah, check it out. I'm posting the link to the video as well. But today, yeah, we are going to be pivoting. This is a good subject because one, for those of you that may be tuning in here for the first time, my co-host Jose Jr., he is 17 years plus experience in healthcare consulting, but he currently runs a mental telehealth practice as well. So today's session, we're going to be talking about there's some new legislation potentially in 2025, the Medicare
It's a
Telehealth.
new final rule. The legislation's being held up because nobody wanted to do anything during this session.
Yeah.
It's a lame duck now, but I imagine it's going to get taken a look at this coming one, but we'll see. You never know what Congress is not going to do recession, you know?
Oh yeah.
It's almost like they're afraid of doing their jobs.
It's yeah, at the end of the year, everybody's checked out
Celebrating
maybe
or
or
commiserating.
sell. Yeah, exactly. Exactly. But um Jose, what's I'm trying to where should we start with this?
So
I'm gonna post an article here in chat as well
yeah,
that we're gonna
yeah.
be sort of
So
keying in
basically,
off
when it
of.
comes to telemedicine, there were certain rules that we were operating under in different time periods, right? So if we go back to the time before internet, telemedicine was literally just it it dealt with only those visits that were not done in the office. So I could have done it through telephone. All right. And then there was a period of time where everything in telemedicine was based on where the provider was situated and not necessarily where the patient was situated. So it was convenient and inconvenient at the same time, right? It was an awful half measure, which the government loves to do. Anybody that's dealt with government knows what I'm talking about with these half measures. But basically, what it was a patient had to go to a location that had already been pre-approved to do telemedicine, and the provider could be in another place. The idea behind it was that this way, more rural areas could see and have consults and exposure and access to care for specialists that were normally in more metropolitan areas, right? So, let's say you don't have a neurosurgeon because your county has 100,000 people. Well, then guess what? In the next county over, or in some cases the next state over, because sometimes that's closer than the next biggest city to you, then you have a specialist that could then telemedicine in to see patients and do consults that way. Then in 2016, don't hold me to it, federal government finally passed something in regards to telemedicine where they had to pay the same amount for the visits as if they were in person. Then shortly after that, we had COVID. And if you didn't have telemedicine, you didn't eat for 2 years, basically, a year and a half, 2 years, unless you were emergency or were under a very beneficial state. And then now we're here. So basically, there was a lot of during COVID, the back end of the back end of the Trump administration and the beginning of the Biden administration, there were certain leniencies in regards to telemedicine. You could establish a patient through telemedicine rather than the patient coming to the office to be established. You could prescribe certain medications without much discovery or much information or evidence. Those had been whittled down. all the way to the point to where some people may remember an acceptable form of telemedicine was FaceTiming a patient, like on your phone. Clearly, that is not a HIPAA compliant situation.
That was during COVID, is
That
when
was
that was
during
allowed.
COVID.
Wow.
Yeah, yeah. It was allowed. Well, it wasn't necessarily that it was allowed, but they were going to turn a blind eye because they knew that the federal government knew that a lot of people had not had much experience with telemedicine. Because up
Sure.
until that 2019 era, it was niche practices and higher technologically savvy individuals were the ones using telemedicine. COVID came through, everybody learned telemedicine, everybody learned how easy it was to Zoom. Every EHR has a video conferencing tool now attached to it, which helps with the compliance aspect. And now we're here today with the extension of those COVID guidelines, which means that the things that are allowed are not as free as during COVID. So you can't use FaceTime and things like that. And you can't establish patients for most things depending on what you're doing. But it has increased, and I believe, and most people in the industry believe, this Pandora's box is already open and it's not going to get closed. The convenience is too readily available. The quality of care is not significantly different than in person for most things. That would be applicable, obviously. I'm not going to do a surgery through telemedicine, right?
Mhm.
I'm not going to be doing a biopsy or some kind of procedure. But what telemedicine does do is it allows for us to more or less, in a primary care setting, we can triage the patient. So I can have a provider from home treat patients and say, hey, okay, here's your Z-Pack. It's that time of year. Buy. Here's your Tamiflu here. Buy. You don't have to come to the office for something so basic. Now you only need to come to the office for something that's a little bit more, that requires a little bit more work, right? Like, hey, I've
Sure.
got this weird thing in my neck, or I've got this weird thing poking out of my arm. Okay, well, yeah, come to the office. I need to physically examine that still. Telemedicine is not taking over that role, but structured properly, it's difficult for me to find a specialty that would not benefit from the use of it and the flexibilities that it allows, because it's a way to increase revenue without having to increase your bottom line. Right. So I know a lot of epi clients are in the physical medicines, whether they're chiropractors or dentists or chiropractors, dentists, PTs.
Yep.
Obviously, you can't do a spinal manipulation on somebody who's not in the office. However, there are other things that you can bill for, right? Like, hey, I can do a follow up with the patient. Hey, this is the results of your x-rays. These are the results of your MRI. Yeah. So what, you want to do a spinal manipulation through telemedicine, Tracy? I'd love to I'd love to practice that with you and let's see how that goes, right? From here. So then we have, of
It's
course,
easy.
like my wife would bring out a magic wand from Harry Potter World or in Universal and do that, right? So it's really a matter of
It's
prioritizing and then streamlining your protocols, right? So if I'm in a physical medicine space where I usually have to touch a patient, there are always things that you're doing, working with the patient on that don't need to be in the office. Hey, Susie, let me see you do your exercises from home. Hey, let me make sure you have enough space. Hey, let me make sure you're using this equipment properly. You can bill for all of these as long as it is appropriate, right? Like some of these, yeah, they may be a nurse code, may not be a straight 99213 or, an office outpatient visit, or they may not be a complete physical therapy session. But then again, if I'm a PT, most insurances are paying me a block rate no matter what. So screw it. I'll take my $45 and move on. You know what I mean? So it's all about looking at what my structure is, looking at what the services that I'm rendering are, and then going from there. And so you're kind of working backwards rather than forwards, right?
right.
Things get tricky when you start playing with medications and prescribing. which is where the guideline really creates a problem without creating a problem. And here's what I mean. It creates a problem in that you can't logically work your mind around this one. So federally, the DEA has said, hey, you can do telemedicine. You can establish a patient for opioid use disorder and prescribe them Suboxone or methadone without ever seeing them in the office, without ever doing any real evaluation. However, on the second visit, you then have to actually at least look up their you have to do an evaluation, or another provider has to do an evaluation before they get their second dose. Suboxone and methadone are
Interesting.
class 3 medications, but they're
Right.
used specifically for opioid use disorder. This
Uh,
limitation is in place for those, but it is not in place for something like Adderall.
is Adderall fall under the same class?
Adderall is technically a class 2 because it's an
Two.
amphetamine. But I'm
Okay.
using Adderall because that's the one that everybody knows for treating ADHD. So your kid can't sit still unless they're already established prescribing a class 2 through telemedicine. You need to be very, very careful and double check your state laws. DEA doesn't really like it. I don't normally recommend it. Establish the patient first in the office, then do whatever you want afterwards within your scope of practice, right? It makes things far, far simpler. It's far easier to justify for malpractice, for billing, for anybody looking at any quality control issues, pharmacies being a pain in the butt, whatever the case may be, right? So it's absolutely something to where you want to be clever. Well, not necessarily clever, but really understand that rule, right? So when I'm dealing with the DEA and I'm dealing with my scope of practice, I really want to make sure that this is a game of Monopoly at my friend's house. As in, I don't want to play unless I know what the house rules are, right? Because if you don't know
Yeah.
what the house rules are, you're going to go straight to jail. Do not pass go. Do not collect $200. I want to know what the rules are. I want to know um what the limitations are, right? So for me, there's a lot for me in our mental health practice, there's a lot of, ambient situations. Anything that's class 2, I need to establish you in the office before we move forward with this. But there are certain things that we can do that are far safer, and yet it's we're just adding extra layers of protection, right? So on a compliance side, we want to remember that the reason why we don't want a simple video conferencing tool is because of the compliance factor of all this, right? The HIPAA issues
HIPAA.
involved with this. Now, remember that your provider can open this, and they should only open this in an enclosed location like their home office that is closed off from family members, or in their office. They really shouldn't be doing this at a Starbucks, in a hotel lobby, in an open room, and where anybody can walk in and out. Now, that's where our liability as a practice comes into play. However, on the flip side of this, the patient can do this call wherever they wish, which is the beauty of it. They can take a non-smoker smoke break, or smoke break, or I'm going to go take a walk real quick, jump on the call, see the provider. Everybody's happy. We all move on with life. The patient didn't lose any money because they didn't leave work. They didn't have to leave work, and the provider still gets the visit. You know what I mean? So it's very there's some conveniences there. Again, for certain things, it doesn't make sense. You can't get an injection through telemedicine,
Yeah. I
but you
have a
can go
question
over the
for you.
console. You can
Okay.
go over options for surgeries. You can do all of that you would normally do in the office. You can do that through telemedicine. So for expediency's sake, for convenience's sake, you can book these and really have those providers productive and efficient.
I read something in that article that you can
Which
that
article
patient
are you
that
talking about? The release from the DEA?
no, there's you were mentioning earlier about how do you know where the patient is going to be? whether it's
Mm.
Starbucks or anywhere. But I also read in the article I posted in chat on Tano Consultants that there's some sort of audio only, I guess, is
So when you
inclusive.
talk,
So
yeah,
it's like
so
now that you have audio only, then you truly don't know
okay, so there's
where they're
how can
gonna
I put
be or
this? There's where there is an opportunity, there's the ability for manipulation or deception, right? So with telemedicine, one of the main things that we train our providers on is asking the patient whether they are in an area where our providers are licensed to practice medicine. Because you're right, the ability to practice to use
you
telemedicine
just
means that
you
you could be in China for all I know. As
right.
long as the patient, in our case, as long as the patient is in within the borders of the state of Florida, we are good to go. And we have some patients that literally live in Alabama or Georgia. They will drive in the 45 minutes into Florida. Every 90 days, they'll do this. They'll drive into the boundaries of the state of Florida, tell us, yes, I am in Florida. Perfect. Now we can do the visit. If not, if they tell you no, you cannot practice medicine then.
I see. So
Does that mean
put
you can't see the patient? Not necessarily. It just means that it needs to be coded and billed differently. It's not a medication management session now. Now it's a coaching session. I can't bill insurance for this. I can't send a script for this,
right.
right? Um, this is where opportunities for chiros and PTs really opens up though because now I can have patients that, of course, again, depending on the scope of practice in various states and where these patients are, all the normal CYA legalese, um, you can have coaching sessions with patients because the word coach and fitness coach is how can I put this? In most states, it doesn't really have a definition. It doesn't have a licensed definition. So I can have a program where patients are paying me on a monthly residual and we're just working on their mobility. Why? Because, hey, I love that you want to stay limber so that way if you get hurt or when you get hurt, you will be able to recover faster or you have more flexibility to be able to carry out your normal daily lifestyle. Because I don't know about you, Ray, but the older I get, the harder it is to move around sometimes, right? So this is something to where for certain populations is absolutely an opportunity for a gold mine. And you can do it in a lot of different ways. You can set it up within a patient portal, and it's just videos for them to do exercises. You can set it up as one-to-one coaching sessions, and now you're not limited by the four walls and roof of your brick and mortar practice,
Right.
right? And this requires a little bit of different style of marketing, but it doesn't require how can I put this? A lot of hard investment. It's just different kind of word of mouth.
I just think in those
So
cases that just to your point, setting up exercise programs, it's like ensuring that
yeah,
it's a convenience factor, right? That's the biggest
yeah.
thing for both parties.
Well, and if I'm a provider, right? If I'm a PT, if I'm a chiro, I can I can literally just record a video, a 30, 45-second video. Boop, this is how to do this stretch. Boop, this is how to do this stretch. Boop, this is how to do this. Sorry, I'm used to holding a camcorder like it's the 90s, right?
FaceTime.
I'm not holding a bazooka here. It's a camcorder, all right? Anybody that remembers these knows what I'm talking about.
I still have mine.
Yes. Huh?
I still
You
have one.
remember those VHS tapes that would pop out the
Yeah.
side too?
Yes.
You couldn't be left-handed because the tape would pop out in your face? Yeah.
Yeah.
Oh yeah, unless you had the fancy camcorder that then the viewfinder would go on both sides. But
I didn't
you
have the
could
fancy
record the
one.
video once and then have it on your website, and then it's just, hey, just refer to this video. Hey, just refer to this video. Then I don't have to waste my time as a provider explaining this exercise 1,000 times, 100 times in a month. No, no, no. Hey, just go. Check out that video. Check out these 5 videos. Do them once a day, twice a day, whatever is being recommended, right? Because if they're not in your state and you're not a provider in that state, you're not prescribing, you're recommending, you're coaching. You know what I mean? Like,
Yeah.
so this is where you want to work on that legalese and find out what that proper verbiage is so we don't get ourselves into any kind of trouble. But this is nothing new, just different, right? And now with the DEA allowing the flexibilities, it's pretty nice. Now, in the actual DEA newsletter for December, they sent out heads up on electronic prescription fraud. I love having conversations with my healthcare attorneys because we will literally just poke holes at any process, and it's just a way that we pass the time. And one of the ways that we have problems with the electronic prescribing software is some states don't have what Florida has to begin with, which we call it here eForce. And basically, what that is, it's a database where any patient, any provider that prescribes a controlled substance to a patient ends up on this database. And we can literally look up by provider, by pharmacy, or by patient all the medications that they've been given. Going back to the beginning of the eForce program, which I want to say is 16, 17. I know other states have different names for it, just like Medicaid is called something different in 40 different states, right? But the reason why I mention this is because you want to be aware of where there's opportunities for exploitation. This
Yeah,
is just like when we're talking about disaster
you
preparedness.
don't want to deal with the
I have
thrill
a plan,
seekers.
I have a standard operating procedure. Let's throw a wrench in that plan. Let's test our plan. Let's test our responses, our standard operating procedures, and see how sturdy they really are. Because a house of cards looks sturdy until a strong wind comes through. Right? Everybody remembers the story of the 3 little pigs. Straw House thought he was good, and then, until he wasn't. You know what I mean?
Yeah.
So we really want to make sure that we're good to go there. One of the things I will say too, if you're in charge of compliance, or you have a team that's in charge of different types of compliance, there are newsletters, not just the EPI compliance newsletter goes out monthly, but specific agencies, specific federal and state agencies will send out monthly newsletters about things that are coming up, about things that have been changed. So you can be on the front end of this rather than on the back end of this. So I knew that this extension of the guidelines was going to happen because there's an entire process for this. So what normally happens is it kind of follows the federal budgetary guideline, right? At the beginning of the year, January, February, they kind of come up with an idea. March through May, they shoot out what the idea is going to be, and then they open it up for public question and answer. So then, if you know what's going on, hey, wait a minute, maybe I need to get involved with this. Maybe I need to have the front end conversation of this, like when this was happening with the opioid use disorder. I submitted a ticket because I wanted to say, hey, look, I love the extension of the telemedicine rules. I don't like that you're only picking it up for OUD patients. I think that there are other opportunities with other classifications of patients that could benefit from this ease of access, right? But if you know, if you can be on the front end of it, they take these conversations into account when they come up with their final rule. And there will be plenty of agencies that you can look up. Hey, they came out with an idea in March and April, and then everybody in the trenches between the hospital organizations, state agencies, and patients and patient advocates and offices went in and they said, no, this is stupid. And so they were like, nope, we killed that idea. And then they'll go mum on it and come up with another idea. But if everything goes by smoothly and they take everything into account, then the rule usually comes into place in November, December. They report the rule for it to come into effect January 1st. So this
Was
way, it
it?
kind of just coincides with the calendar year, which is the same thing that normally happens. For example, most people will be aware of it in regards to Medicare deductibles. They'll talk about, hey,
Right.
we're going to raise the Medicare deductible. Everybody will complain, yay or nay. And then November, they'll let everybody know. So then that way you can let your patients know in December. They send out the new Medicare cards because now they send them out every bloody year or some crap, every 2 years at the latest. And then January kicks in. So,
So there's a
um,
question from Cheryl. She's asked,
yep,
so if a telemed visit via video in 2025 will continue to be covered in 2025 or not, and if yes, then paid at the same rate as if visit is done in person. Example, for now, now we bill an E&M code with modifier
yep,
95. Do we continue to bill this
yep.
code?
So before you used to have to put in, make sure that if you have, I don't know what state you're in, Cheryl, but some states have to put in a modifier for certain insurances to bill because the telemedicine visit. Double check on that piece, but it pays the same rate because it's the E&M code. For a while there, with before 2016, 2017, when they passed that Telemedicine Parity Act, they were paying they were paying pennies on the dollar. It was like
Yes.
50% on an E&M code because you did telemedicine. So the insurances were like, well, screw you. You're not spending as much money or time. Therefore, it's not the same visit. Now, especially because of COVID, you can do a normal visit and get paid at the normal rate. Keep in mind, Medicare loves to play games in regards to, hey, if I'm eating my macro and MIPS, if it applies to me, that up or down percentage on what is the actual rate. Uh, Cheryl, I don't know what state you're in off the top of my head, but Medicare it has to have available to it because it's a federal agency. Okay, Cheryl, you're in Florida. All right. Then you need to go to FCSO, and look up the fee schedule. The MPFS fee schedule. All right.
What's the
And you
acronym
want
again, Jose?
FCSO, First Coast Service Options. First Coast Service Options is the fiscal intermediary for Medicare. And that's how you find out what Medicare should be paying out in regards to each and every visit. You can look this up for any code that has ever been in existence. You can look up ancient codes, you can look up current codes. It will show you and it will break it all down. And then you just find which area is the one that's appropriate for you. Every single fiscal intermediary has this database that you can look up the code. I just don't know all the intermediaries off the top of my head. I will say that a lot of times in the US, it usually ends up being like a Blue Cross subsection. It's a separate business, but it's the Blue Cross franchise. Like here, First Coast Service Options is Florida Blue. They just call it First Coast Service Options for purposes of government contracts. So and so just find out who your fiscal intermediary is, and then you can find out what the codes are, what it pays out at. And then you can find out if they also needs a modifier or not. Now, that's for Medicare. For the private insurances, every single one of them is different. Every single product within every single insurance is different. So that you'll have to play with. The Medicare will continue to pay. Yes, yes, it is. Yes, Medicare will continue to pay for telemedication visits. Yes, you're good to go there. In regards to the flexibility, really came out, Cheryl, in regards to the controlled medications is really where the flexibility is. That's where the discussion is now. The idea that telemedicine is going back into a box, that's done with. The federal government isn't even playing with that. The DEA, HHS, they're all on the same page. So you're good to go there. Then now, obviously, there is no more COVID-19 bonus. As in, you're not going to get a bonus if you're a hospital or office treating patients that have COVID-19. That shit's done. But everything else is on the table. Um, so yeah, so you really want to take a look and make sure that you have a good process for everything. Because the other problem with telemedicine can be that the communication between the provider, support staff, and the patient post visit can be lacking if you're not careful. So if you're an
So
office that heavily depends on follow-up visits or sending out orders, then you want to make sure that the communication with that provider is there. So you essentially have a virtual MA that is the assistant to the provider, and then the go-between, obviously, for everything else. But yes, I mean it's
So if I just was digging into the rural side of things, if you're an
yes.
RHC, you just bill through it. I guess it's just a different code that you're using for these distant site, I guess,
Yeah, so basically
services.
it's like I can't remember the code. I can't remember the modifier right now.
Was it G to it says G or I don't know if this is a modifier G2025.
Sure.
Yeah, I don't know.
I'm not a coder.
It's in the
Um,
article, everyone.
yeah, all right. So yeah, so there used to be a modifier that you had to put in there for that. And then the federal government, however, does recommend, highly recommend that video be used over just a phone visit.
Okay.
So if I have to go to a phone call, then I should highly notate in my note that we did a phone call visit because our telemedicine connection failed, or patient wasn't able to do telemedicine because of technical difficulties, something along those lines. You don't want to do it very often. You want to do it very sparingly. If your provider is going to be using a phone, make sure that they have something that spoofs the phone number so it's not their personal cell phone number. Trust me, you don't want to make that mistake. You'll only make it once. So, but see, again, these are different pieces in play that you only come from either learning from your mistakes or learning from other people's mistakes.
Have you seen any I was gonna say, since you're in the industry, have you seen any mistakes or
Oh God,
any
mistakes are like air. It's all around you, right? So there's different kinds of mistakes, right? So, I've seen the telemedicine mistakes where the provider is not in a private location. I've seen the mistake we can call or misunderstanding. What if audio is done only? Yeah, you can still bill, Cheryl, but you can still bill if it's audio only, but you want to make sure that the documentation is there that you tried video and it wasn't working for whatever reason. Because the federal government will do it, but they highly recommend that it be through video. If it's an eval, don't do it. Don't bill it. You might be able to get away with it, but it's going to ping a red flag if anybody looks at those notes. If it's a follow up, you have more wiggle room. If you're not prescribing controlled medications, again, you have more wiggle room, right? So it's all dependent upon what am I doing. Um, Look at it like this: it is completely normal for an ER to call a specialist for a phone consult for a patient that's in the ER. But that specialist is not the one that's going to be writing the orders for the medication, for the surgery, for something along those lines. That's that ER
ER
doctor,
doctor?
right? So
Yeah.
you got to take a look at what that risk profile is for what you're doing and what specialty you're in, right? Like if let's say I'm an OB in an OBGYN office, right? Yeah, I can do a lot of this. Oh, let me see what's going on. Hey, that's patient, tell me what's going on. Hey, now with everybody having a Fitbit or an Apple or smartwatch, what's your pulse like? What are the contractions like? What's the spacing on it? Oh yeah, okay, you've got Braxton Hicks. Don't worry about it. You're fine. You know what I mean? Like you can do some basic things like that and not have to screw up your schedule for the day in the office or you know what I mean? Like cause unnecessary stressors on everybody involved, right? But if it's something where you're like, oh, your water broke, then what are you doing still there? You close this
Did you come
call
in?
out and get to the hospital, right? I'll see you there. So it's just adjusting what that risk profile for my practice is. Every practice has um, higher risk activities than their normal daily activities. And then you also have the lower risk activities. You don't want to do the higher risk stuff virtually. We're not at that point yet. It's just not there, right? So it's just understanding what that is like. So if I go back to a primary care or an OB office, I can do a lot of little crap online. That's not a problem, especially for my existing patients. For new patients, I probably want to eval them in the office and get a feel for who they are. Um, Make sure that they're not reading certain things because we have definitely tested, and I have tested this, and it is extremely possible that you can set up a visit. I'm gonna say it, but it's gonna be a problem later, I'm sure. Um, you can set up a visit online with a provider, pay cash, send in a fake license to the front office, see the provider with a fake name. The name's not gonna pop up in the registry. They can send medications out. Right? Then it's up to the pharmacy, and then we're playing malpractice games, right? So we have to make sure. That's why in our office, we won't do new patients through telemedicine. Like there has to be a very bloody good reason. Um, One of those reasons would be I can't get out of my house because the hurricane was just here yesterday. You know what I mean? Like something like that, fine, but I'm seeing you for the follow up in 2 weeks in the office, no excuses, right? But those are protocols that we set up in the office. I'm not the clinician, I'm in the admin side, I'm on the risk management side. So I work with my medical director where he gives me his clinical guidelines. I go through my admin guidelines, my billing guidelines, my pick an alphabet agency guidelines, and then we sort it out somewhere in the middle, right? So this way, it's a collaborative rather than me dictating it as an authoritarian. It usually creates more compliance, especially with the more difficult population that is providers.
I would assume, in just in the telehealth industry in general, there's got to be some, you know, patient compliance issues. You know, it's so
Oh,
easy to,
absolutely. I mean, we had a patient
but
that was they actually went through the trouble of getting a lawyer and they wanted to sue us because some of this patient's employees were finding about things about his care details. And we were like, well, where did you decide to take the call with the provider? Oh, I was at my work site. When the bloody hell do you expect, Bob? You know what I mean? Like
right, that's
lawyer.
crazy.
This would be known as do I know anything about those specific? I don't know anything about them off the top of my head, Cheryl, but I can take a look at them and I can get back to you on that. So hey, no problem. So basically it's just a matter of making sure that everyone's understand of their again, patients are not dumb. They could be lazy, but they're not dumb. Right? Like the population that you would think is the dumbest kind of patient is the one that is the best at filling out paperwork.
True.
Just, again, I'll probably get canceled for something like that, but I'm calling it like I see it. You know what I mean? Like you're going to have situations if a patient's not aware of what's going on. So this is where you'll see a lot of patients that are taking the calls from their car, from the bathroom, or from their office and the door is closed. You know what I mean? Or from their bedroom. On the behavioral health side, I have found that my providers actually like seeing the conditions that they're living in because it gives them more information and insight into what's going on around them.
That's a good
But
point.
again, that's because behavioral health, it's a little bit different.
Sure.
Um, However, if I'm in ortho or if I'm in physical medicine and I want to take a look at, hey, you're falling a lot. I wonder why that is. Let me, being able to see what the ground looks like, or if there is a ground, you know what I mean? Like, is there how much trash is in their house? All of a sudden you can see, okay, well, now I know what's going on. Or if I'm an allergist and I can't figure out why this patient is why is this patient is having problems, and I see that they have 15 pets running around their house, right? Then all of a sudden, okay, I think we have the
Makes
answer,
sense.
Bob. It's the
Mhm.
15 cats you've got, or the 12 birds and three dogs and one cat. You got a freaking zoo in there. So it can be rather enlightening. And talking to providers, do conducting telemedicine gives us answers that the patient's not necessarily hiding, but they're not giving it to us because we're not asking the right question. You know what I mean? If I'm sitting here and I'm like, hey, Susie, you have a diabetes problem, you have a high blood pressure problem, you have a high cholesterol problem, you're obese, and we're about to take off your foot, and she's taking this call from her couch, and you can see the mega gulp on the cat on the table, along with, leftovers from lunch or breakfast, and it's far too much food for one person. Yeah, you can be like, hey, Susie, are you not even self-aware enough to hide this evidence? You know what I mean? Like, what are we doing, Susie? I can't prescribe you or help you or set you up for the lap band surgery, which a lot of insurances are very, very strict now on putting patients on the lap band surgery. Or now that the GLP-1s are being covered by insurances, I'm sure there are going to be more guidelines as to how I can prescribe them. Then you got to help me help you. You got to that Kevin Hart bit about you.
You
You're
gotta
at
want to
you
be
got to hit the
you gotta want to
70.
be compliant too.
Yeah, yeah, but so then it comes back to
Help
not
yourself.
necessarily a HIPAA compliance, but it becomes uh a healthcare compliance, a
Right,
clinical compliance.
right.
You know what I mean? Like it gives us more data in that respect. Like, hey, okay, I've got knee problems. My patient is a Medicare patient. They live in a bloody townhouse where they have to go up and down the stairs 20 times a day. Well,
Yeah,
maybe you need to move into a one story. Maybe that's a conversation, because what's going to happen is that you're going to end up being so sedentary because of the pain. You're either going to be stuck on the second floor or you're going to be stuck on the first floor. What's the point of having two floors then? So why pay for two floors if you only need one? So it's absolutely something where telemedicine offers flexibilities. Knowing where those guide rails are really, really helps things out. The extension really for this year really was catered more towards the opioid use disorder than anything else. It's just kind of understood that telemedicine is here to stay and that it's got to pay out at normal office rates. Um, Certain insurances are playing a few different games in regards to copays in regards to that. So you'll have to take a look at specific insurances. I know Florida Blue, depending on the product, was having like a $15 copay or a $25 copay or some shit, depending on what was going on there. But that just depends on, again, separate insurances, which it's just getting so hard to keep track of all these products, honestly. So,
I know we've
so
touched
yeah,
on
so
it.
I mean, anybody's got any questions though, definitely throw them in the chat. I know that Ray, when we probably the next 2 weeks, we can do a follow-up for um a day in the life of a breech patient.
We could
Shit.
do that.
So we can kind of play that route because normally we're on the provider side.
Right.
Well, luckily, I get to be part of the change healthcare problem. So I'm 1 in 3, Ray. I'm 1 in 3. So
I'm getting flashbacks because you remember I used to work for the weight loss centers, what, 7, 8 years ago, and
yep,
you mentioned the E-Force. We use that too because
yep,
we prescribed Adipex to weight loss patients,
yep.
and you'd be surprised how many we find in that database that try to game the system.
Well, it's
Um,
not even, it's, how can I put
and
it?
not even that, but just our protocols in general.
Yeah.
We would coach them. Um, it was a ketonic diet, so uh, no carbs at all. But we'd have
Yeah.
good foods to eat, obviously proteins and how to use spices and stuff. If you're sick of just eating chicken or beef and you want to season up, there's dry rubs and stuff that you can use. But I mean, for the most part, we saw great outcomes, but there was, some patients that really just they did it. It's like they paid the money
Yeah.
and they didn't gain weight, they
Just
didn't
kept
lose
on doing what
weight,
they
they
were
just
doing,
kept
and just
on.
took the pills and expected everything to
I
work.
thought the pill was gonna exactly. They thought the pill was gonna be the game changer,
Pill
but
solves
really,
everything, don't you know?
there's much more to it.
If you
So
got a problem, there's a pill for that.
it's investing in yourself and willingness to make a change, but kind of applies here in a
Yeah,
sense.
absolutely. Absolutely.
We did well at the time, we didn't do telehealth with this. We did follow-up calls, and for the most part our follow-up appointments were in the office because we weighed them, on the scale and took their BMI
So
and all that
I
stuff.
would honestly say for a situation that's doing like a weight loss, a vanity clinic, if you will, vanity medicine clinic,
Hmm.
the follow-ups are efficient to do through telemedicine, but I don't know
No,
if you're going to
absolutely.
get the perceived value that you would want to show through telemedicine. Does
Well,
that make any
yeah,
sense?
I agree. I agree.
You'd
Because
want to you'd
you
want to
can
show,
put
hey,
all
look, we're
your
paying thousands of dollars for this program. Show me that this is going to work.
yeah.
I want to get the full red carpet experience, baby. Like this. We're talking about my mortgage payment right now that you're getting from me.
No, absolutely.
So it kind of
It
it
was
kind of
better suited
depends
for
on.
the in office visits, for those
Yeah,
type of
yeah. But I mean,
coaching
again, though,
sessions
you
and
could
all
also
that.
do it based on the packages, right? Like in
Absolutely.
that case, oh, hey, you're not getting your B12 injection, then hey, all right, well, then we can do the quick follow-up call through telemedicine, make sure you're good to go. You can weigh yourself from home. That way, you're using the same weight you use every day, and we can kind of track it that way. Give you a quick virtual high five or a virtual, pow pow. Be like, hey, you need to, do better or whatever, or show me what you've been eating. You
Yeah,
can confirm the meal prep again. You couldn't do that if they came to the office.
it's true.
Show me what's in your fridge right now. Show me what's in your pantry. And the first thing you see is
It-
double stuffed Oreos. Come
uh,
on.
no, very true. I mean, there's some benefits I think in the vanity industry with this kind of thing, especially the weight loss.
Yeah. So, I
Um,
mean, there's a lot of different ways to play with telemedicine. It's again just knowing what the guide rules are, as with everything. You want to make sure that you have a process and then test it. Everybody has that one family member, that one employee that doesn't break rules, but they love to see how flexible the rule is. Have that person try to break your system. There will always be stuff that you can't account for, right? Like on the compliance side of things, we can do everything in our power, but the ransomware hacks that are occurring in the ways that they're occurring, we can't prevent them. It's just we're playing craps at the casino and seeing how it goes, right? We keep on let it ride until it happens, until we crap out, right? Um, but we can control the variables that we can control, right? So we just want to
absolutely.
make sure that we're taking advantage of those situations. What was that? My mom has a phrase for this, and God gave me the wisdom to not worry about the things to gave me the wisdom to worry about the things I can control, the patience to deal with the things I can't, and the cleverness to bury the bodies of those that piss me off. My
The
mom
last
has rocked
part.
with that for the longest
I
time.
love that.
So, I mean,
So
I'm
we'll
not
get
saying
her
bury
on
the
we'll
bodies.
we'll
I'm
get her
just
on an
saying,
episode then.
like,
We'll have her expound on
yeah, yeah, we'll have her
that.
on and she can expound on that one. But yeah, I mean, I just want to make sure that you guys are comfortable with everything that's going on. If you've got any questions, you got any concerns, please, please, please let us know. coming to the end of the year. Ray, I know that the holidays are weird this year. Are we taking any time off?
You know what? I didn't look at the how we sort of follow suit here for Christmas, but let's see. I know we'll be talking next Tuesday and the Tuesday after the
Yep.
17th, the 24th, and I can tell you right now, the 31st probably out of the question. Um,
Okay.
um, the 24th, let me see. We pick a topic for, or that's Christmas Eve. Yeah,
Yep.
to be announced. To be announced on
Okay.
that one. We'll
Okay.
we'll talk about that.
I
But
mean, maybe we move it to Monday for
yeah,
those rather than Tuesday.
we could change up the days for sure. Um, we'll let you guys know about that, but at least for now, we do have a topic in place next week. We're going to be talking about healthcare stress solutions and strategies for a healthier and a happier workplace. And
Ooh, ice
yeah,
cream Fridays.
I was going to say epi compliance.
Oh yeah, there's that too. There's that too.
Hey,
So I mean,
listen,
perfect,
we make
perfect.
compliance
Well then,
simple, you know, make it easier for you, less stressful. But
yeah.
no, that's going to be a good subject. I'm actually pushing to maybe get your dad involved in that one. We'll see. Obviously, as you know, his schedule's busy. But if anybody in chat has any topics that they'd like to recommend to us, let us know. Um, I still have an open slot right now for the 17th. Um, if you have anything interesting, preferably compliance related, but we can always approach something in the healthcare industry itself. Just let us know or feel free to put it in chat. And yeah, but if anybody here has any questions from today's session, please feel free to throw your questions in chat, and Jose and myself will answer here in the next minute or two. You got your lights up yet, Jose? Are
No.
you are you the family that puts the Christmas tree up in November?
No problem, Cheryl. My wife wanted stuff up at the beginning of November. So the Christmas trees are in the house and
Okay.
they've been up for the entire month of November. The exterior falls on me, which means it's gonna have to go up this weekend. So we have some stuff up, but I gotta
I'm
put up the
uh
lights.
I'm on the clock too. This weekend
Yeah,
is
yeah, yeah. So I'm gonna have to work on that stuff. So we'll see how it goes. Luckily, I only do the front facade. I don't go around the house.
that's all you need to do. Do you got the blow ups too, or you got any blow ups this year? Or?
We have one snowman that hangs out in the front yard.
Okay.
We
I
don't have any
got
blow ups yet, but my wife is talking about some of those lights that go on the walls and then doing like a movie night on the garage. And I'm like, it's way too cold for that.
yeah.
So we'll see. We'll see what happens. Usually it's she tells me, hey, I want to do this, and I can delay it about one Christmas season and then it goes up.
I just plan to
So
put lights in my front yard. I gotta light up Santa Claus. I'm gonna put it at the front door, and I got a small set of. I have a front porch. I'm gonna set some lights there and call it a day.
nice, nice. Well, thank you guys. Cheryl, I'm gonna look up those codes and see what the LCD is on those, and then I'll get back to you on that. And that's something that anybody can do as well. If you're ever curious about what the codes are, again, those fiscal intermediaries have to have what's called an LCD, a local CPT description, and it breaks down when, where, and how you can use those codes and modifiers. So definitely, again, these tools are not very easily Googleable. You need to know what you're looking for and where you're looking for it, but the tools do have to exist by law. It's just how long is it going to take you to find it? And that's where consultants come into play. So cool, guys.
Cool. Well, Jose, I appreciate your time and appreciate everybody tuning in today. And we'll see you guys on the next one. Just be on the lookout for the registration link for next week's event.
Absolutely. Thanks.
Take care, Jose. Stay warm.
Yep. Bye.
show.